So good afternoon, ladies and gentlemen. Welcome to 24th edition of Prague Rhythm Workshop. And today we have pre-Congress meeting, which is called Practical Sessions. You know that we had to cancel one edition in 2020 because of COVID, and last year we had meeting only online. So I'm very happy that we can meet today and in subsequent days in person here, but we have also many participants online. So that will be a hybrid meeting, as we call it today. And we prepared for today a series of lectures about conventional ablations with the practical recommendations and advices. And I would like to encourage you and also people who are online to ask questions. And people who are online, they can ask via chat, and you obviously can ask question directly here. But discussion will be after each block. So first there will be 3 lectures, and then before break will be one discussion, and a second discussion will be at the end of this day. And of course, I hope that tomorrow you will come and enjoy the meeting. It starts at 11 o'clock, and we have a series of live demonstrations for you and a lot of nice lectures. So saying that, I would like to start this practical sessions today afternoon, and enjoy. And don't be shy to ask questions. Thank you very much.
Hello, my name is Wichterle, and my task today is to tell you how to ablate AV nodal reentry tachycardia. AV nodal reentry tachycardia is usually an easy target for ablation, but not in all cases. Difficulties are due to complex substrate consisting of dispersed or non-uniform extensions of perinodal tissue, functional features of virtual pathways, and relatively problematic region to manipulate the ablation catheter in terms of stability, accuracy, and good contact. That is why it is time from time difficult to eliminate the arrhythmia, and at the same time to minimize the risk of inadvertent AV block. There are many ideas how electrical waveform exits from perinodal tissue and how it re-enters back again. The circuits, of course, vary depending on phenotype of AVNRT, like presented at the figure here, but don't worry. This lecture will not be focused on complicated physiology of AVNRT. All these virtual circuits are relatively weakly supported by mapping data. Nevertheless, it is important to keep in mind that this figure, and remember that the site of ablation success may be finally found not only at the typical site of triangle of Koch, but also at the ostium of the coronary sinus, or even deeper at the coronary sinus roof. And in rare cases, the AVNRT have to be ablated from the inferoseptal aspect of mitral annulus. Correct diagnosis is a good starting point, of course, especially for atypical form of AVNRT. The differential diagnosis from atrial tachycardias and AVRT may be a significant issue. Our normal catheter setting is decapolar steerable catheter inside coronary sinus, quadripolar catheter at his, and mapping catheter at RV septum at the beginning, and frequently by a long sheath for more precise manipulation. We prefer to start with RV pacing because this reveals or excludes majority of concealed accessory pathways. Not all of them, of course, and not with 100% certainty. The difficulties may arise with those located paraseptally, and I will mention this later. Another benefit from RV pacing is that it may facilitate the induction of atypical, i.e. fast, slow AVNRT. The next step is atrial pacing, either incremental or programmed stimulation. First, this helps to assess whether AV nodal dual physiology is present. And second, it frequently induces the SVT. And when there is simultaneous activation of atria and ventricles, it usually indicates typical slow-fast AV NRT, which is the most frequent in the population. For other SVTs with non-simultaneous AV sequences, differential diagnosis between atypical AV NRT, AT, and AVRT have to be made. Coronary sinus activation sequence is usually of limited value. Variable AV and VA intervals usually indicate atrial tachycardia. Mode of spontaneous SVT termination can be helpful. If the last event is ventricular activity, it doesn't tell anything. If the last event, however, is atrial activity, this excludes atrial tachycardia almost for sure. Specific pacing maneuvers should be performed in case of uncertainty. I personally prefer incremental ventricular pacing up to the loss of VA conduction. If the VA block is associated with arrhythmia termination, it indicates rather specifically AV nodal reentrant mechanism. On the other hand, VA-AV sequence upon the cessation of pacing suggests atrial tachycardia. His synchronous pacing is well known, as well as Parahisian pacing, which is almost absolutely sensitive and specific for the detection or exclusion of retrogradely conducting paraseptal accessory pathways. Inducibility of AV NRT is not only essential for confirming the clinical diagnosis. Reproducible inducibility also establishes the most important procedural endpoint, i.e. non-inducibility of AV NRT after the ablation. We are not able to induce AV NRT by single extra stimulus. We use 2 extra stimuli. I already mentioned induction protocol from ventricle for atypical AV NRT. And we try, of course, to pace from more than one atrial side when we are not successful from one side. And of course, isopreal challenge is critical. Importantly, the dose of isopreal or rate of isopreal should be diligently titrated, because frequently both very low or very high isopreal rates are not successful in AV NRT induction. Sometimes AV NRT can be induced despite very suggestive clinical diagnosis. And one study suggested AV NRT induction by low intensity RF current. This study included 31 cases with AV NRT in non-inducibility after a reasonable number of attempts. And they applied multiple low energy, 25 watts, low temperature, 45 degrees of centigrade, barons into AV junction region that resulted to induction in 65% of patients. We all know that this occurs during regular AV NRT procedures. Subsequently, the procedural endpoint was non-inducibility in inducible patients and slow pathway elimination in non-inducible patients. And the authors reported success rate of 100%. When we look for slow pathway, for the slow pathway, typical site is the region between the insertion of septal leaflet of tricuspid valve that is anterior or slightly superior to the ostium of coronary sinus, here annotated as area number 1. And when ablation at that site fails, we usually continue ablation with the catheter hooked inside the coronary sinus, either a little bit inferiorly or anteriorly. This is annotated here as area number 2. And the last resort for the right-sided access is the ablation deeper inside the roof of coronary sinus, area number 3. And in rare cases, the AV NRT have to be ablated from the inferoseptal aspect of mitral annulus, and I will show you one such a case later. Importantly, slow pathway is defined not only anatomically, it must be mapped electroanatomically. It is usually done in sinus rhythm by seeking for typical slow pathway electrogram that is defined by morphology, timing, AV amplitude ratio, and other tricks are also useful. Coronary sinus pacing, AV, A plus V simultaneous capture and utility of unipolar recordings. And I will mention all these features separately. This slide shows a nice his bundle electrogram here, slow pathway electrogram here with small atrial and large ventricular component because of proximity of tricuspid annulus. And the AV voltage ratio can be used for navigation of the ablation catheter in the region between septal tricuspid annulus and coronary sinus. Please note the transition of AV voltage ratio when the catheter moves away from the annulus to the anterior ostium of coronary sinus, and finally a little bit deeper inside the coronary sinus. Faster coronary sinus pacing is used to prolong age interval and disclose whether the slow pathway electrogram doesn't contain his far field. In this example, nothing is visible on the mapping catheter during coronary sinus pacing, so that the ablation at that site should be relatively safe. Nice position of ablation catheter at slow pathway region close to the tricuspid annulus is associated with simultaneous capture of atria and ventricles when pacing is commenced. Capture of ventricle only or atrium only usually indicates 2 distal or 2 proximal catheter positions and is likely less effective site for initial burn. When this capture is consistent, it also indicates good contact and limited catheter sliding in anteroposterior direction because of respiration. Some operators utilize unipolar electrograms. This strategy may improve the relatively low spatial discrimination when using bipolar electrogram only. In this example, the morphology of slow pathway electrogram in bipolar setting is reasonably nice. However, unipolar electrograms is much sharper when recorded from the proximal electrode than from the distal electrode, and it indicates that the catheter tip is not in contact with the myocardium, and that the ablation here will be likely ineffective. For the treatment of atypical AVNRT, empirical slow pathway ablation can be used, of course, and it is frequently effective. On the other hand, atypical AVNRT can be mapped more specifically because the electrical wavefront exits at the slow pathway, unlike to typical AVNRT that exits at the fast pathway region close to his electrogram. And that is why activation mapping helps to identify the true position of the slow pathway and improve the efficacy of the procedure. In case of difficult inducibility of atypical AVNRT, another strategy can be used that is based on mapping of the earliest atrial activity during the ventricular pacing. When the pacing is relatively fast, retrograde conduction occurs preferentially via slow pathway, and that we want to map. And frequently, the exit from the slow pathway is located at the anteroinferior ostium of the coronary sinus. And when the ablation is ineffective despite the activation mapping, some authors suggest to create a short linear lesion between this site and empirical site at the septal tricuspid annulus. Now we move to ablation itself. We use conventional non-irrigated 4 mm tip catheter. Radiofrequency ablation is done in power control mode with adjustment titration to achieve junctional response. It usually means deliveries of 20, 25, or 30 watts for 20, 30, or 40 seconds. Some operators use continuous or intermittent atrial pacing after the onset of junctional rhythm in order to check for intact AV conduction, but we don't do this. We observe the signs of imminent AV block and stop ablation in case of AV prolongation without junctional rhythm, too fast junctional rhythm, VA block during junctional rhythm, or atrium delay during junctional rhythm. And we also stop ablation if the AVNRT is induced during radiofrequency energy delivery or in case of bursts of atrial ectopy. There is one interesting study on power titration. They started at 5 watts with power increments of 5 watts every 5 seconds until junctional response. And when this was achieved, power was finally incremented by 10 watts, and the delivery continued for a total of 120 seconds or 2 minutes. And the clinical outcome was nice with reasonable safety profile. Junctional response to ablation is important mark of successful procedure. However, the presence of junctional rhythm itself doesn't guarantee the AV nodal reentry non-inducibility. The other authors investigated the characteristics of junctional response during the slow pathway ablation and identified some features that were associated with procedural success. It was either early onset of junctional during ablation, cumulative number of junctional beats more than 10 to 15, cycle length ratio, sinus against junctional rhythm more than 1.25, junctional rhythm faster by 25% compared to sinus rhythm, and prolonged post-ablation junctional rhythm. On the other hand, absence of junctional rhythm usually indicates ineffective ablation. Specifically, in one study, acute effect was achieved only in 12% of patients with absence of junctional rhythm during ablation. What about procedural endpoints? Arrhythmia non-inducibility is the primary and the most important endpoint. Elimination of AV nodal dual physiology is not necessary because this is a rather strict endpoint that only slightly increases the success rate, but at the same time significantly increases the risk of complications, namely AV block, of course. Not only dual physiology is allowed to persist, but also isolated AV nodal echo beats are allowed. On the other hand, isopreal challenge is essential in all patients, even if there are some studies that indicate that isopreal can be omitted in case of easily inducible AV-nRT at baseline. It means without isopreal, or the same criterion combined with complete slow pathway ablation during the procedure. What to do when AV-nRT is non-inducible despite many attempts? There are 2 studies indicating that such patients might be eligible for empirical slow pathway ablation if SVT is nicely documented, particularly with a short RP interval. And if there is also documented dual AV nodal physiology with echo beats, it is another clue for eligibility for empirical AV slow pathway ablation. And there are 2 studies. One study observed more than 60% recurrence when such patients were not ablated because of non-inducibility during the procedure. And on the contrary, the other study reported a reasonable success rate of 84%. There are some concerns whether sedation doesn't interfere with the inducibility of AV-nRT. This was investigated in this randomized study, ablation study, and when the ablation was performed in deep sedation, and it was not associated with any change of EP parameters and with no change of AV-nRT inducibility. Therefore, there is absolutely no need to avoid this medication in our patients with AV-nRT, especially in young women. And this is the last study I want to present today. It investigated in a randomized fashion whether waiting time of 30 minutes after the AV-nRT ablation improves the clinical outcome of patients. The answer was negative. Therefore, waiting period can be omitted in standard procedures, importantly in standard procedures. But I can imagine that prolonged waiting and testing may be of value in selected patients at discretion of operator. I promised at the beginning to show the case of left-sided AV-nRT ablation. This was a patient who underwent 3 prior unsuccessful procedures for a typical AV-nRT. The last one was performed with the help of 3D mapping system, and you may appreciate that area of the triangle of Koch was completely covered by ablation lesions that were extended to the ostium of coronary sinus, including lesions deeper inside at the site of coronary sinus roof. And despite this, the procedure failed both acutely and clinically. During the subsequent procedure, we went transeptally to the left atrium and adjusted the catheter position as close as possible to the original location of right-sided slow pathway region. And single ablation at that site that was associated with limited junctional response rendered the arrhythmia non-inducible, and the patient is free from AVNRT recurrences. My take-home messages are as follows. Make the correct diagnosis. Combine the anatomical and electrogram-guided approach. Titrate RF energy. Achieve the adequate junctional response. Adjust the procedural endpoint to baseline inducibility. Prefer safety over efficacy. Think about coronary sinus or left-sided ablation in case of primary failure. And use 3D navigation or contact force sensing in difficult cases. Thank you for watching.
Hello, my name is Petr Peichl, and it's my great pleasure to share with you our experience on ablation of accessory pathway. During this talk, I would like to give you an overview of different mechanisms that may occur in patients with accessory pathway, about the role of ECG in diagnosis of accessory pathway. I believe that's very important because most of it can be done outside the EP lab, and you can come into the EP lab with a lot of knowledge, and I believe that's very important. Obviously, I will talk about catheter ablation of accessory pathway, and I also will put some emphasis on specific scenarios that may occur on accessory pathways, Maheim properties, on PGRT, parahysin pathway, and accessory pathway in Epstein anomaly. Few words about the history. WPW was first described in 1930s, and at that time it was described as a short PR interval bundle block and paroxysmal tachycardia. And the authors that are depicted on the picture generally focus on ways to normalize ECG, to use atropine, to minimize pre-excitation, and use exercise also to normalize QRS complexes. The description of the pre-excitation as an extranodal pathway comes a little bit later. And this is on the right hand, you can see the drawing of what is currently kind of basis of arrhythmias during WPW. This is the kind of scheme how the pre-excitation arises, and this is the scheme how the AVRT orthodromic is formed. The first therapy came in late 60s. It was a surgical approach, obviously. And in 80s, there was a start of the catheter ablation era, and that's the dominant way of treatment for our patients today. And that's what we're going to discuss. So the presence of the accessory pathway can give you different ECG morphologies and different kind of patterns. Obviously, the basic sinus rhythm is manifested with the presence of accessory pathway as a delta wave or form of pre-excitation, abnormal configuration of QRS complex. If you have a arrhythmia which is orthodromic, AVRT, then you have an antegrade conduction over the His conduction system and retrograde over the accessory pathway. Very rarely in clinical practice you can also see antegrade conduction over the accessory pathway, and then it's an antidromic AVRT, which in my clinical practice I've seen only once in clinical ECG. It's much more common to see this in EP lab when we do these maneuvers, but clinically antidromic is quite rare. This is one of the cases they actually we did. This was right-sided accessory pathway. It looks like a white QRS complex tachycardia. You would guess this is probably VT if you don't know that there is a pre-excitation on the 12-lead ECG. And in this particular case, was interesting because there was only intermittent pre-excitation. You would have to be lucky to really see the delta wave because some of those complexes were not pre-excited. Despite that fact, we saw this kind of abnormal morphology, which is compliant with antidromic IVRT. I would like to also emphasize this image. This is something we should teach to everybody in cardiology and even general cardiology, because it's not common nowadays because a lot of accessory pathways are ablated, but still may occur. This is AFib going fast over the accessory pathway. Sometimes people call it pre-excited AF, which is probably not that correct. But generally, is fast. It's broad QRSs with a changing width of the QRSs, and it's irregular. There's some complexes are not pre-excited sometimes, and this is very typical. And it's important because we should not give any drugs. We should proceed directly to cardioversion, should recognize these arrhythmias. And this arrhythmia can be also deadly because this is a tracing of patient that has this AF conducted fast over the rapidly over the accessory pathway, degenerating in this part into the ventricular fibrillation. And the incidence is not high, but actually increases every year for a patient life. And their highest risk of occurring deaths is multiple accessory pathways, symptomatic AVRTs, and very high conduction capacity of the accessory pathway with the pre-excited interval less than 250 milliseconds. And the risk is higher during competitive sports. Although I must say I had one young lady with pre-excitation that seemed to be not that kind of malignant. She never had any of those, and still she died suddenly. And when you have such a scenario in your clinical career, you just think twice not to offer the patient ablation and just send her ablation quite early when the diagnosis is made. If we talk about the accessory pathway, we should recognize that anatomy can be variable, and that there may be different proximal insertion of the bundle. There could be different distal insertions. So proximal insertion can be in atrium, coronary sinus, AV node, fascicle. The distal insertion can be in the ventricle or fascicle. So we can talk about the atrioventricular pathway, which are the common breed that we actually face in the EP lab. But there can be some special situations like fascicular-ventricular accessory pathway, atriofascicular pathway, which is the Maheim time, or some strange nodal-ventricular, nodal-fascicular pathway, which are not that common and not that easy to diagnose. And this is the schematic drawing showing different potential kind of connection of different structures giving different accessory pathways. When we talk about the accessory pathway, we generally still use this kind of description, which is an LAO position of the pathway compared to the mitral and tricuspid valve. So we talk about the anterior, posterior, paraseptal accessory pathway compared to this. This is the best way how to describe the accessory pathways. We should use ECG algorithms for accessory pathway allocation. There are different ones out there. This is the one that I would suggest because I think it's quite simple. It has 4 steps, and it's important to have a proper lead position. That's one step. And the other one is that if you talk about the accessory pathway or delta wave, you should actually look at the initial part of the QRS. So the part of the QRS can be, this is when the delta actually is occurring, the activation over the accessory pathway is occurring. And the best thing is to have a maximal pre-excited QRS, because then you really see when you have a fusion with normal conduction, it's not that obvious. So if it's at the first 40 milliseconds, it's positive. it's positive. If it's a ISO, and can be negative. But there, as you can see, there might be different kind of ways, so the judgment is not that easy. But back to the algorithm, for those pathways that are negative in lead 1, obviously they come from the left side of the heart, and depending whether they are positive or negative in inferior leads, they can be anterior lateral or posterolateral. It's important to recognize those accessory pathways that come from the septal region, or and they usually are epicardial if they are negative in 2-3 AVF, and I'll show you example of those such a pathways, because these are very commonly associated with venous anomaly, or they can be ablated within the bottom of the coronary sinus. So these are very important, negative in 2-3 AVF, because it comes from the very basal or inferior part of the heart going up, so they are negative. Now, and then if you have a kind of V1 negative or ISO, then you have a rather septal pathway, depending how it is in the inferior leads. It's positive, negative. You can have anteroseptal, midseptal, posteroseptal. If it's a V1 is positive, it's a right lateral accessory pathway. If you rule out this, you end up with the kind of location of the accessory pathway. So these are the ones that are good to recognize up front, because you know that your day might be a bit difficult. So this would be so-called epicardial accessory pathway from or CS, or some venous anomaly at the CS. It's negative in 2-3 AVF, and it's becoming very basal, so it's a basal part in the inferior. And for these patients, it's strongly suggested to do angiography of the coronary sinus, because the accessory pathway is commonly either in the diverticulum that might be present in the inferior part, or there's some branches. This is the posterolateral branch or posterior branch of the coronary sinus. When you cannulate that branch with the ablation catheter, you may find the AP potential and do the successful ablation there. So this is the ECG morphology that I strongly suggest you to recognize, because the angio may help to localize these accessory, these venous structures, and mapping meticulously all those structures may help you to do the ablation right. The other potentially kind of difficult pathway are those that are mid-septal, because these are associated most likely with the risk of damaging the conduction system and damaging the AV node. And as you can see, it's a negative delta wave in V1, and it's positive 2, negative rather 3. So it's somewhere in the mid-septum. And those are, and I will talk about them later. One part of the doing the WPW ablation is to recognize correctly whether the patient does or does not have a pre-excitation. So if you encounter ECG like this and somebody comes to you and you're to say, okay, this is for EP study and ablation or not, it's not that straightforward, because there are some situations when there might be kind of pseudo pre-excitation. Patients with hypertrophic cardiomyopathy, for example, Danon disease, have a ECG that really look like pre-excited, and it's not. And there are some non-invasive ways how to really recognize that. One way is to look at the 24-hour Holter monitoring, because there usually are some supraventricular or extrasystoles, and not by rule, but commonly you can see kind of augmentation of pre-excitation associated with those premature supraventricular beats, because the AV node is not conducting properly at that time. So you can see change of the configuration and really kind of augmentation of the accessory pathway, and that can give you a hint and a corrective diagnosis. On the other hand, this is the patient with hypertrophic cardiomyopathy, and if I would show you this part, you would say maybe yes, maybe not. But if you look, there are a bunch of supraventricular ectopic beats which do not change the QRS morphology. So this is strongly against the presence of the accessory pathway, at least the one that is antegradally conducting. There obviously might be concealed hidden accessory pathway, but that's in the hypertrophic cardiomyopathy kind of unlikely scenario. Most people believe that the Q waves should be negative, that the delta waves should be positive, but sometimes it then mimic kind of Q wave after myocardial infarction. So people with the posterior septal accessory pathway are believed to have a alt posterior or inferior MI. And this is kind of Holter monitoring of a patient that has a Q wave, and suddenly, abruptly during the day, he loses the Q wave. And obviously, this is the delta wave, and only negative one. And that explains that. And if you would really look closely, you can see that with this Q wave or delta wave, the PQ is shorter than the narrowing of the QRS, and the PQ gets longer, which again goes some aberrancy, because for aberrancy, if you have a longer PQ, you would have a wider QRS. That is not the case. Stress test can be also used in patients with kind of not clear pre-excitation, and what you should see there is the kind of disappearance of pre-excitation. So if you look at the lead V5, V6, you can see during the exercise the QRS normalizes, and if there is a sudden change with the low kind of exercise level, it means that the pathway is conducting very poorly, and that it should be low risk accessory pathway. That's all the books show. Should be abrupt loss of the pre-excitation, and this is the typical kind of scenario that may occur. The other option is to give adenosine. This is done by, is displayed in here, that you can see that there is a kind of normal QRS, and suddenly the QRS gets wider, and there is this kind of pre-excited QRSs that kind of occurred. Doesn't mean to lead to the complete AV block. It's not because there is a parahisian accessory pathway, as was in this case. The problem with giving adenosine, it can give you the chance of giving atrial fibrillation, and having atrial fibrillation in the context of accessory pathway can give you a risk of having also this fastly conducted, rapidly conducted, and the atrial fibrillation over accessory pathway, and the need for defibrillation. So now I would like to say some words about how to diagnose these patients in the EP lab. And I wouldn't go really into much details. There are a lot of maneuvers how to differentiate different arrhythmias, but I would like to stress two tests that we use. You should have some kind of maneuvers that you are used to how to use it, and that are available for you. So first is so-called His synchronous pacing. This is done during tachycardia, and when you deliver one single extra beat into the ventricle, which it will, if there is an accessory pathway, shorten the next atrium. So you deliver that at the time of the His refractory. So this was the His. This is the cycle length of the arrhythmia, and you see here a ventricle ectopic beat, which led to the advancement of the atrium. This atrium is conducted over the accessory pathway by capturing ventricle and not able to really conduct retroclading over the His, by possibility to advance the next atrium. This is a proof of the presence of the accessory pathway. So this is so-called His synchronous pacing. The other maneuver which I would like to mention is so-called parahisian pacing. This is done, and that's more difficult to do because you have to pace just at the close to the His, but not in the capture the atrium, which may be sometimes a kind of a problem in terms of interpretation, whether this was only the His capture or also the atrial capture. So generally, you apply low and high output for this pacing. And you can see whether you captured only myocardium in the ventricle in this region, or you also captured His by seeing whether the QRS gets narrow. If you have a narrow QRS, you have a his capture. And then you compare this only myocardial capture and the his capture in terms of the VA. So how long does it take to conduct to the atrium? So this is how it would look like. So this is a pacing when you have a broader QRS, and you can see that there is a kind of retrograde hiss here, probably. And the VA is 114 milliseconds to the iliac coronary sinus. And if you capture the hiss, meaning that you actually should be having a kind of this time conduction earlier to the atrium, and the VA is still short and doesn't change. This means that in this particular case, there is a presence of the posterior septal probably or parahisian accessory pathway. If you would have no pathway, this myocardial capture would result in the longer VA interval, which is not in this particular case. So now I will just move on the mapping and ablation of the accessory pathway. What are the strategies we currently use? So some tricks and tips how to do the correct, select the correct position. Generally, we should select the site that has a accessory pathway potential, which should be tiny, sharp potential present in the site. It should have also side when there's because we are on an annulus short AV or VA interval, and if you're mapping antegrade or the distal insertion in a ventricle, and we have a ventricle electrogram, there should be absence of R wave or QS pattern in unipolar potential, and I will show that later. We should always ablate at the site when there is a large ventricle electrogram, because that means that if you are on an annulus with the catheter, there is usually very small atrium and big ventricle. That's the annular signal. So large ventricle electrogram means that you're close to the ventricle muscle. You should eliminate the accessory pathway within first seconds of radiofrequency application. And when you're not successful, you can change the access or approach. I will show you how. And you should also use some pacing maneuvers, and I'll show you also something about oblique pathways and ablations due to the pathway slanting. So generally, this is what used to be for many years the standard how to map left-sided accessory pathway using retrograde access, going through the aorta, through the ventricle, sticking your catheter underneath the mitral valve. Senior guys know how to do it very well because they did it. They know how to maneuver the catheter only on flora. Younger guys not that experience there because they are much more better with the transeptal approach, but this should be the signal. So you have this atrial component, ventricle component, something high frequency there, and there is no R, but the QS in the unipolar signal. So this looks like a fancy, nice potential for ablation. The transeptal approach is nowadays more used for probably because we do a lot of AFib procedures. Obviously, you can map the distal insertion. Again, there is this QS in the unipolar signal, and then in this you can see that there is an atrial component and some funny thing in between, and then there is this ventricle electrogram. So this would be also a good kind of spot. My experience is if you're dealing with the left lateral accessory pathway, I really like to have the catheter all over the roof of the left atrium because it gives you better stability there. This is maybe too distal, so the catheter will be here, but just this gives you kind of stable potential or stable location. If you're dealing with the posteroseptal, this is also transeptal left-sided accessory pathway. I use only the kind of short catheter out of the sheet to get a better contact, to pull back the catheter to get a good kind of stability. And you can also map the proximal insertion of the or atrial insertion if you want. So this is not fully conducted beat. We are pacing in the ventricle. This is ventricle electrogram in ablation. This is the atrial component, but this is fully kind of captured. So this is the conduction here. This might be some accessory pathway potential, and this is left lateral because the CS1 is leading. So this again looks like a interesting signal to ablate, and this should be the kind of way how to do this. So you start the ablation, and within 1 second or few seconds, you have immediate disappearance of the pre-excitation. Means that you actually were exactly at the side of the accessory pathway, and you were able to really limit the conduction through the pathway. And if you have a later or delayed kind of effect of the ablation, usually the pathway will come back. There are difficult pathways out there, and part of the difficulty in mapping may come from the oblique accessory pathway or pathway slanting. So generally what it's described here, and this is very nice paper about that, is that if you have a different insertion of the accessory pathway in the proximal distal part, you may have a kind of funny kind of mapping feeling from the presence. So for example, if you're pacing from the ventricle and you have a kind of parallel conduction of the pathway with the ventricle myocardium, this will happen. And generally, if you measure just the shortest VA interval, it will be somewhere in the distal pole, so somewhere here, although the accessory pathway is here. So this would be an accessory pathway potential. This would also be interesting area to ablate, but generally this may be not a, this would be a good target, although it doesn't look that appealing, the signal. Obviously, if you change the sequence and you pace from CS distal the ventricle and you pace like this, so the whole sequence reverses, and you can have a kind of this kind of signal that is able to really differentiate. So these oblique accessory pathway sometimes require that you map in detail the distal insertion in the proximal insertion, and you may find some interesting potential in between, and you can ablate in between. So this may make the things difficult. Some special scenarios, right-sided pathways are deemed to be kind of more difficult. In the larger series, there's lower success rate for them. And my personal recommendation, if you have the opportunity to use decoupler or do decoupler catheter for them, because then give you a kind of overview of the whole tricuspid annulus, and you can really see where you are. The stabilizing sheet is very important. Sometimes it's for some of those going from above, from SVC jugular vein, may give you better stability. What I really like for those pathways to have a ICE, intracardiac echo, and I will show you why. The reason is that the tricuspid annulus is a very movable structure, especially for the lateral part. We measure TAPSE. We measure this part is moving a lot. 2 centimeters is the normal TAPSE. And if you just change this to the kind of movement, if we to the movement of the tricuspid annulus and the stability of the catheter, we'll find out that the catheter is not stable because it moves in and out of the tricuspid annulus. So this is the normal during the sinus rhythm. If you see this with the intracardiac echo, obviously you can try to stabilize there, but if you withdraw too much, you will end up in the appendage for this anterolateral accessory pathway, for example. So one way, for example, how to stabilize the catheter more is to use high rate pacing. So if you pace RV 150 beats per minute, you can see that the movement is diminished. This is the 70s, there's a lot of contraction. People use this for TAVI to somehow suppress the cardiac output. We can use this to suppress the motion. And as you can see, you can have much better kind of contact and stability in this particular place. Sometimes what may be useful also for tricuspid, for the tricuspid accessory pathway, is to use this under the tricuspid valve kind of position. This was a case of the third redo of the WPW for anterolateral position. So everything was burned here, and we couldn't really do some much there. So we put using Agilis the catheter inside the right ventricle and come back underneath the this anterior leaflet of the tricuspid valve. And as you can see, this was a very stable position, and it was single application there that actually get rid of the pre-excitation and also the conduction over the accessory pathway. So this may help. For some of those inferiorly located tricuspid or right-sided accessory pathway, the Agilis is very helpful because especially in young ladies, the tricuspid annulus is very movable, and also the cavotricutid isthmus is very movable. This is also a case of the patient, of the lady patient that had she had about 5 ablation procedures prior, and it was difficult even from above. We tried, and it was difficult to stabilize the catheter there. At that time they had no echo, no Agilis, but with the use of echo and Agilis, just to compress and kind of pin down the tissue towards the liver, we were able to do it finally with not that amount of energy, but with amount of stability that was kind of necessary to really reach the complete block. Few words about parahesian pathways. They might be risky because of the risk of AV block. The risk is surprisingly lower for anteroseptal. People are afraid to ablate close to the his. The risk is somehow higher for the so-called mid-septal, generally meaning the his is protected by the fibrous tissue, but if you damage conduction, you usually damage very easily the AV node. So for those mid-septals, you have to be kind of careful. And how to prevent the problems? Well, try to seek the signal without his potential. What I strongly recommend, start on the ventricular sides of big V. The AV node, you don't really create the AV block if you have a really large ventricle, because there's usually his is protected by the fibrous tissue. And generally it's recommended to start on low power. And if you encounter junctional beats, PQ prolongation, or widening QRX complexes, usually right bundle branch block, it means that you are too much in the ventricle. And if you have a junctional beats during this, you should start pace in atrium to see really whether the AV conduction is still present. Some people use cryo. Some people recommend to use a non-coronary aortic cusp for those. We have one patient that we were able to ablate within the non-coronary cusp. This is the reason why it may be in some patients good. So this is the kind of tricuspid annulus. This is the aorta non-coronary cusp, and this would be the region of his. And as you see, the catheter here is not that stable. It jumps in and out, and you can position it more in. But if you go from the other side and you stick your catheter from aorta down here, or this case here, but you can obviously probably the location would be here for the parahesian pathway, you can have much more stable, and usually you are not able to damage the AV conduction from the non-coronary cusp. At least I haven't seen any damage from there. Obviously, it's easy to, if your catheter is in this location, to do some damage. So that may be a trick for some of those accessory pathway that may be accessible out there. Few words about the Mannheim pathway. These are so-called atriofascicular accessory pathway. They have only antegrade conduction, and they are most likely due to the accessory AV node that is located on the right side of the tricuspid annulus, or the lateral side. And what's important, the pre-excitation may be absent on the ECG. Generally, the only hint that there is a Mannheim is that there's some strange configuration of V1, V2, and some people are believed, looking at this ECG, that there is a kind of old anterior myocardial infarction septal. So those people with Mannheim are sometimes sent for coronary angiography because of some disease, ischemic disease, and it's not problem of a scar, it's problem of the change in the activation sequence. So and abnormality in only V1 and V2. Some of the Mannheim pathway can be very slowly conducting. What this is showing is the pacing in the right atrial appendage, and this is the time it takes to get to the ventricle through the Mannheim. So this is very long conduction. If you do not pace in the right atrium, if you just pace from the CS, you may completely miss it because the coronary sinus is close to the AV node, so you don't really reach it. But pacing close to the accessory pathway help, and you see that there is a LBBB morphology of these kind of ECG leads, which generally is a compliant of conduction of the slowly conducting accessory pathway of Mannheim type. The Mannheim tachycardia then goes from the atrium towards this kind of accessory, I call it accessory hiss. It's called Mannheim potential, but if you believe there is an AV node somewhere here, it's something like hiss, and then goes to the ventricle with retrograde activation over hiss, and then go back to the atrium and so on and so forth. And the point here is some people try to ablate in the ventricle in the earliest ventricle activation, which I strongly discourage, because then because it's a usually kind of fine network of different fibers, and the place to ablate is on the lateral annulus. It's somewhere here when you have the Mannheim potential. If you just start to ablate in the ventricle, you may just slow down the conduction and may have the Mannheim tachycardia incessant, because then it becomes very slow and easy to start and maintain. So this would be during the atrial pacing from the appendage. There's this Mannheim potential, this tiny hiss-like potential, and if you start to ablate, you immediately see narrowing of the QRSs. So this is still conduction over the Mannheim. This is the normal conduction. You see the PQ doesn't change, but it only changed the morphology, so you have to watch for these very tiny details and for these procedures. A few words about permanent junctional reciprocating tachycardia. That's not that common. Typically negative P waves, 2-3 AVF, slightly higher heart rate, BC in adults only rarely. It might do incessant tachycardia, which leads to cardiomyopathy, but in adults that's not that likely. ECG is quite self kind of evident that the diagnosis is, especially if it's a kind of still ongoing rhythm. Obviously, it can be atrial tachycardia from that region. There's one hint how to differentiate Mannheim from other very similar tachycardias, and this is shown here in the ECG. It's not the perfect tracing, I'm sorry for it, but it shows what it's supposed to show. So if you have a Mannheim, it is a burst of PGRT here, and the typical for Mannheim is that the initial kind of beats of the Mannheim are quite fast, and then the accessory pathway, which is decremental, gets tired. So you have a progressive slowing. So the first beat is the earliest or the fastest, and then it progressively slows down till it doesn't conduct, and then you have a sinus beat, and then you have a reinitiation when the conduction pathway gets kind of in condition, so it starts to conduct and does this. So if you see this kind of rapid beat initially and then slowing down, that's typical of a Mannheim feature. The ablation of PGRT is usually easy. It's somewhere on the tricuspid annulus close to the CS, so it's not that difficult, and the stability is usually there, and you just map the earliest atrial activity. And lastly, I would like to talk about Epstein anomaly, because that makes the ablation quite difficult. Those patients have usually multiple accessory pathways, and there's a lower success rate because of the enlarged atrium and a lot of fragmented low potential electrograms in the area. So this is the run of Mannheim, and this is the pre-excited QRSs during sinus rhythm. And the important part when you're trying to do this mapping is to really aim your target here at what's supposed to be the origin of the annulus, not when there really is displaced the tricuspid valve, because this part, so-called atrial, the right ventricle, is full of a lot of fragmented potentials. It's not that easy to interpret them. So obviously in this image, it would be that here would be the target. Here is 2 inside the RV. And one way is to put something into the right coronary artery, like a wire, to see where's the real annulus. The other part or the other option is to use intracardiac echo, because then you have a kind of catheter, and this would be a kind of black dot, which would be the right coronary artery, and this not ablate here, but ablate at this former AV sulcus or AV groove that there is. So lastly, I will talk about fasciculoventricular pathway, which are very, very, very rare. It looks like pre-excitation, but if you put inside the electrogram, you will see this kind of pattern. So you have a H and a very short HV interval. And if you administer kind of atrial extrasystole, you will see prolongation of AH interval with the same morphology of the QRS complex with no change HV interval. In normal AV pathway, H would really go inside the ventricle, and you would have a maximal pre-excitation. So if you have this kind of pattern, this is fasciculoventricular pathway, and this is not able to sustain any arrhythmia, and do not ablate, because you can damage the infrahisian conduction. You can obviously administer adenosine to really verify that this is the situation, and there is, by blocking AV node, you will prove that this was not this was fasciculoventricular pathway. So thank you for your attention. I hope I covered most of the most important parts, and I'm looking to meet you in person during the Congress. Thank you.
Ladies and gentlemen, my name is Jana Hašková, and I'm one of the electrophysiologists of the EP team at ICAM. And my role today is to talk about how to ablate typical atrial flutter. Flutter ablation was performed first time in 1990, and with using DC shock in the postseptal region where a slow conduction was observed. Soon after, radiofrequency current was introduced. Later activation sequences was mapped with multipolar catheters, and a circuit was described. Here you can see one counterclockwise flutter or counterclockwise activation during atrial flutter. Ablation was performed across the isthmus, and here you can see some gap signals or some fragmented signals on the line. However, the goal was only interrupt arrhythmia and prevent non-inducibility of atrial flutter. For this reason, the early experiences were not so good. How we can see, acute success varied between 66 to 94%, and there were many recurrences of arrhythmia. The description of the strategy to assess the bidirectional block on CTI was described in mid-90s. Pacing was from proximal CS and from left right atrium, how you can see here. The advent of electroanatomical mapping improved understanding to the circuit and helped to perform ablation, especially in some difficult cases. A group from Bordeaux described the so-called differential pacing that could differentiate definitive block from slow conduction across the ablation line. With a new approach with confirmation of block on CTI, better results can be achieved, as you can see here in this meta-analysis of later studies on flutter ablation. And then ablation of atrial flutter has become recommended in guidelines, and today is class 1 indication, as you can see on this table from recent SC guidelines on supraventricular tachycardia. In addition, some studies have documented that atrial flutter ablation really reduces risk of ischemic stroke. So, which factors determine the success of ablation for atrial flutter? We can divide it into the two categories, like operator dependent and operator independent. Start with ablation strategy. In LAO view, you see arrangement of the catheters and corresponding signals on the right panel here. Electrogram from the ablation catheter should be in the middle. In area view, you see how the length of the cavotricuspidal isthmus can be estimated based on the local electrograms from the ablation catheter. At the annulus part, we can see large ventricular signal and small atrial signal or electrogram. On the contrary, at the eustachian ridge, we can observe large atrium and very small ventricle, like a far-field ventricle electrograms. The ablation is performed point by point, starting at the tricuspid annulus. After this application first, we can observe small split of the electrogram. Single impulse has to travel around the lesion. With more lesions, or is split wider. And finally, when the block is achieved, there is wide split And second electrograms is good if it's on the latest among our electrograms. Here is another example of ablation of the isthmus. We can observe narrow, double, or narrow split of the electrogram in ablation catheter after a few lesions. And finally, wide split after achievement of the block. Bidirectional block is still confirmed by pacing from both sides, from a pacing from low right atrium and from sinus coronarius pacing. The second electrogram in the ablation catheter is the latest. In case of unidirectional block, the pacing from both sides provides different timing of signals. Stimulation from septal part shows block, but pacing from the left right atrium results in a shorter interval, how you can see here, and it's why, because it's slow conduction in lateral septal direction. In case of bidirectional block, both intervals are almost the same, how you can see on this example. Using this strategy, we described back in 2000 an abstract acute success of ablation with 4 mm catheter in 97%. And there was no differences between case performed during atrial flutter or during pacing from right atrium. Using this strategy of point-by-point ablation, we can look for some gap signals during ready procedures. And this can facilitate the ablation. This is an example of other strategy based on delineation of the cavitricuspidal isthmus by electroanatomical mapping system. 3 points marked a tricuspidal annulus and 3 other points mark IVC. The ablation is performed between them. This strategy decreases, how you can see here, flutter time. This simple strategy was used in randomized error flutter study in comparison with conventional electrogram and flutter-guided approach. It showed that electroanatomical mapping system reduced significantly flutter time during procedure, but was a little bit more expensive. But acute access was the same in both groups. Later, other studies have shown significant reduction of flutter time and radiation dose when using electroanatomical mapping systems during ablation. Electroanatomical mapping can help in some specific cases. How you can see an example here, we can see some gaps in the line, and on the right panel we can see example of conduction from lateral right atrium and around both sides of the IVC. We should also mention strategy of voltage-guided ablation of Canadian authors. They believe that ablation at the site of highest local voltage is destroying this thick trabeculation and allow achieved block with less applications. However, this strategy doesn't improve the success and doesn't change the procedural or flutter time during the procedure. Now we can discuss the influence of the catheter tip in the results of ablation. The advent of 8 mm catheter resulted in improvement of efficacy and efficiency of ablation as documented in this small series from our group or our lab. Ablation with 8 mm catheters was faster, required the flutter time, and was 100% successful. Cool-tip catheter didn't improve results of ablation as shown this panel from left side, but a gold-tip catheter showed some small benefit in comparison with platinum iridium catheter in the Aurum 8 study. However, head-to-head comparison of irrigated catheter, 8 mm gold-tip catheter, and 8 mm tip catheter, this didn't show any significant differences. Catheter tissue contact is another parameter that can influence the success of ablation. Here you can see on intracardiac echocardiograms good and bad contact of the catheter with the tissue. The corresponding graphs of impedance show gradual drop in a good position or good contact, or fluctuation of impedance during bad contact. Some studies use a contact force sensing catheter to document reduction of RF application, and like you can see here, and a high proportion of ablation with more than 10 grams contact force. However, clinical benefit was unknown. Subsequent randomized study didn't show any benefit of contact force sensing as compared with conventional irrigated tip catheter. Finally, operator can choose some novel technology for ablation. This recent study with the novel diamond temp catheter showed shortening of procedural time and flutter time as compared with 8 millimeters catheter. Diamond temp has multiple temperature sensors and that can allow safe temperature-guided irrigated ablation with higher energy. We have experiences with the novel mapping and ablation system Affera, which use 9 millimeter lattice tip catheter and allows delivery of high energy of RF or pulse field energy. An example of sphere 9 catheter during ablation of CTI, you can see here. Block was achieved usually after 3 to 5 application of 5-second duration. This is the first report on the results of atrial fibrillation or flutter ablation with lattice tip catheter and high energy of RF. You can see time for CTI ablation was around 2 minutes. We have also some off-label experiences with pulse field ablation of CTI. In this case, you see a Farvive catheter on CTI, achieving a block in 43 seconds. Okay, let's move to the operator impedance factors which determine the success of CTI ablation. How we everybody know, anatomy of CTI can be very heterogeneous and can be a reason for difficult ablation. Early studies showed variable anatomy of CTI using angiography, and other studies used CT to explore anatomy of CTI and its variants. And 3D transesophageal echocardiography can show anatomy of the CTI in real time. In our lab, we prefer to use intracardiac echocardiography. This you can see several examples of different anatomy of the CTI as seen by eyes. Here you can see flat and long CTI, here hypermobile and short CTI. This example shows some very abnormal anatomy with small recesses and no signal is this thin part of the isthmus. Without seeing this detail, ablation could be very difficult. Here is an example of hypermobile isthmus with a prominent eustachian ridge, how you can see here. And you can see how difficult it is to keep the ablation catheter in the right position. In such cases, we use a backhand position of this catheter, like you can see on this picture here. Its eustachian ridge was a difficulty to achieve the good position with this catheter and contact with the tissue. Here is our recent retrospective study of anatomy of CTI isthmus in 138 patients, and how you can see 42% of patients had hypermobile isthmus or isthmus with a prominent eustachian ridge. It was interestingly because a patient with a reduced left ejection fraction from left ventricle showed a less hypermobility of the isthmus. Here you can see this slide with the pragmatic approach for atrial flutter ablation. After confirmation of diagnosis, followed by catheter ablation, and in a case with some problem, you use ice. But more recently, we changed our strategy and we prefer to use in every case of CTI ablation. After visualization of CTI anatomy on echocardiography, we can choose a type of catheter for ablation. With these new technologies, such as pulse field, our future will be probably more shiny. Dear ladies and gentlemen, thank you so much for your attention, and I hope you enjoy Pragrhythm workshop as well.
So this was first part of this practical session afternoon, and we have time for discussion. So any questions from the audience here, or any questions coming from chat? Don't be shy to ask anything about the ablations. Okay, Asa?
For accessory pathways, what kind of catheter are you using? Contact force, irrigated, not tried it?
I think everybody uses different, but Peter will answer.
For most of the accessory pathways, we use irrigated tip catheters, like for all other procedures. And contact force, not really. We didn't really use those catheters a lot. So the answer is my preferred way would be irrigated tip. And if it's a plain left-sided accessory pathway, we do it just with X-ray. If it's a somewhat more complex thing, or it's a redo after some other procedure, we would use 3D mapping system. And obviously, it's a special discipline, the accessory pathway ablation. There are not that many accessory pathways. We have one accessory pathway per month or per 2 months. So it's like 12 to 10 to 12 ablation of accessory pathway per, maybe more.
25.
20. Okay, so it's double, but it feels like it's like a fight over who is going to do it, because there are not that many. So, but most of them are easy. Some of them are difficult. And I would like to apologize, because I recorded the lecture. As I understood now, there was some mistakes and nonsenses. So I do apologize about the PGRT and this ECG tracing of PGRT with rapid kind of activation in the initial part and then slowing down, which means this is PGRT, obviously. This is not Maheim. But I do apologize for it, because it was a late night recording, and it was a long day probably. So I do recognize Maheim and PGRT, but that evening I didn't. And it's good that I didn't ablate that evening anymore.
Any other question or comment? Antonio?
For left lateral accessory pathway, what kind of approach do you prefer? Transseptal or retroactive approach?
Depends who you ask. If you ask kind of senior guys that started like 25 years ago, the retrograde
That's
was
me.
that retrograde was the way to go, and I mean they can do it pretty fast. And that time there were debates, like Karl-Heinz Cook had kind of this team for debate that you can do the ablation with just one single catheter. That's all you need, going retrograde. And we moved since that, and nowadays for younger people to do transseptal is a kind of part of daily routine, and it's still doable. Transseptally very well. So for most of the cases, for our approach would be transseptal for left-sided accessory pathway. Obviously, it's good to know how to do it also the other way, because sometimes it doesn't work for whatever reason, because there is some anatomical peculiarity that we cannot really kind of somehow overcome. So then if you go retrograded, it can be one single shot, because you just embed it. They're much more stable, the catheter is underneath. If you just underneath the leaflet, there's no way, there's no movement of the catheter. It's very, very stable, and it can deliver very nice lesion if you're on the right spot. With the transseptal approach, there is a movement of the lateral annulus, and you can slip into the appendage if it's a really lateral. So you pull back and you will slip in the appendage, which is close. So there might be some issues in terms of the stability. Obviously, it can be done both ways. It's good to know how to do it both ways, because if one doesn't work for whatever reason, it's good to have the other available.
I think the main advantage of going retrograde in a left-sided pathways if it's if it's a overt pre-excitation, so you can map directly ventricular insertion. That's the beauty of that. And the second is stability. So if you are trained, I mean, how to map retrogradely underneath the leaflet, and that requires only a few tricks, but people usually are afraid to get out from the ventricle, so they start to bend in the middle of the ventricle in between papillary muscles, and that's too bad because then you have limited maneuverability. So you have to really pull back in between inflow and outflow, and then to bend the catheter underneath the leaflet. And then you only rotate clockwise or counterclockwise, and you can get, in most of the patients, very quickly to the spot, and you have very good stability, and it really shows such a nice signal as was seen on one of these slides. If you have concealed pathway, then obviously it's better to map atrial insertion or go directly to the pathway if you take this advantage of changing activation, pacing from high ventricle like outflow tract, you change the activation as seen on that slide from Sonny Jackman, and then you can unmask the accessory pathway potential, and you can really ablate there. So it depends obviously on experience, depends on the individual patient, it depends on the history. Sometimes it's a redo, so you have to do something differently. I think it's good, as Peter said, it's good to know all different approaches, because it's in EP there is no single way how to do things. Similarly, like there are many ways to Rome, as usually people say. I mean, there are also many ways to Prague. There are many ways to ablate accessory pathways.
A great help for me was to use I really like intracardiac echo, so also for these procedures, some of them, not just for the left lateral, then you not probably need it, but if you go, for example, for the right-sided pathways, I try to elucidate during the procedure, during the presentation, you can really use it to see how the stability is there. You can maybe pace rapidly in the atria or ventricles to really diminish the movement and deliver better lesion. And also, you can embed it also on the right side, the catheter underneath the tricuspid leaflets. That's really helpful. So for these kind of cases, I really like also intracardiac echo as a kind of tool that will help me. There are, for example, ways that we used to do some of the pathways from above, from jugular approach, because we felt that's maybe better, because the stability will be better. With the Agilis and intracardiac echo, that was not necessary for a very, very long time, as far as I know, because with both of these two, you can really get a very good stability and probably a good lesion to really do it.
I fully agree, because before the advent of steerable sheath, there was a series of a collection of these preformed sheaths from Schwartz. But the problem is that it was designed to get in parallel to the annulus. And it maybe fitted in 1 out of the 10 patients. And if it did not fit in that particular patient, you had really nightmare to place the catheter. And this movement is, as seen nicely on echo, is really in this direction. So it was really very difficult to ablate before the advent of Agilis. And with Agilis, and if you use, again, you can go to for ventricular insertion, because you can do looping, and you can go underneath the septal leaflet, you can go underneath anterior or lateral leaflet, and it's so easy, and especially if you have eyes. So you can really pinpoint exactly the hinge of the valve, and you can have very good stability, and you don't risk any damage to AV nodes, especially in septal area. So I think I strongly agree and I recommend for right-sided pathways to use something like Agilis or steerable sheath in general, and then maybe consider always mapping ventricular insertion rather than go across. The other comment maybe I want to make or stress is that epicardial location of the pathway. I do work sometimes in different labs, and they have redo case for me, and I look at the ECG and said, well, this is epicardial, and they, well, you know, we failed already 2 times, and we are ablating in left side, right side, you know. And you say, did you start with angiogram? No, what angiogram? So when you start with, in this morphology, you start with angiogram of coronary sinus, you see nicely veins, or you can see even this diverticulum. And this is not a typical pathway. That's also important to know. So you have to go sometimes deep into the vein, even 2-3 centimeters. And then you can see a very early activation there. So it's not a conventional pathway. So you have to be prepared to really map all these veins or these structures. And also, you may not see early, let's say, A and V immediately together, you know, because there is like cuff of the muscle. So you have to ablate on different spots. So it's individual. Every case is different, but it's something that is really not typical accessory pathway. But anatomy is very important. So if you start with angio, you have some roadmap where to go, and you can visit each of these veins, or you can go to the diverticulum. If it's in diverticulum, usually the neck of this diverticulum is the location of the pathway, and it's usually like a network of cells, or it's a cuff of the muscle. It's not one single like electrical cable like a typical pathway. And the other very difficult situation is the Epstein anomaly, because it's usually also a piece of muscle, so you have to cut it from one side to another, like from lateral to septal, and like bulldozer, you have to go and point by point and ablate everything on the way, because it's not just one single small musculature, you know. So these are abnormal pathways. On the other hand, Maheim, we discussed a lot about Maheim, is very simple because it's like conduction system. So it's very superficial, and you have even a risk to bump it, and it disappears. So it's also useful to have mapping system, because if you bump it, you can at least record position of this bump, and you can ablate. You can try, because otherwise you have to sometimes abolish the procedure. So these are few remarks about ablation of accessory pathways. Truth is that in our country, and I believe in Italy and Germany and other countries with a long history of ablation, it's very rare now to see really accessory pathways. But there are regions I know, because I travel to these regions, where you can have a lot of these accessory pathways still. So there is I think still need to know how to ablate all these structures.
To think that epicardial accessory pathways is always accessible through the venous system, or you should go really epicardial as well sometimes?
We did a couple times some epicardial mapping, but we never ablated epicardially. So I don't remember in my practice more than 25 years that I would need to do epicardial ablation for accessory pathway. All was done through structures like a coronary sinus or aortic or appendage, never epicardially, truly.
Another question. What's your approach when ablating in coronary sinus to avoid tamponade or coronary artery damages? So you titrate power?
You have to be moderate with power. You know? The people are ablating sometimes with very high power, so we limit usually to 25 to 30, and we use cooling and high flow like 30 or even more, and you can titrate the energy. You can go slowly and keep it longer. So it depends. I mean, if you are in small vein, obviously you have very high impedance and you cannot deliver too much. Sometimes it's also painful. I'm usually not that much afraid of damage of coronary artery, but we had one case ablating in coronary sinus, damaging artery, which necessitated PCI. But it's usually cooling of the artery which prevents damage. But of course, you have to be careful. You have to be careful with energy, and sometimes you really don't need a large amount of energy to ablate successfully. So it's more important to titrate and go slowly and keep it longer rather than ablate with high power and have pop and some problem. I don't know if Peter has some comment.
The comment about this was case with this coronary artery damage during the CS ablation. It was not done WPW ablation, was done during different procedure. It was the cardio-neuro ablation when there was some ganglion plexi believed to be close. So it was a young lady and it was tiny lady. And I believe the risk of damaging these arteries, and it was a very terminal branch. So I believe the risk is higher if the vessel is tiny. So if we do young people, and that's, if you talk to pediatric electrophysiologists about the ablation of Epstein, they are using cryo sometimes, because in very young patients, if there's a lot of ablation along the tricuspid annulus, you can probably damage the right coronary artery in young people or children. In adults, I believe with powers that we are using with flutter ablation, we never do actually damage the right coronary artery. So in young people, the risk is probably higher because of the size. In a normal kind of elderly or kind of middle-aged man, I believe that's very difficult to do. Maybe some smaller branches, but not big arteries. Then you have to be really aggressive.
That's interesting. You mentioned flutter ablation. Unfortunately, these videos did not work in flutter lecture, but if you look at intracardiac echo in flutter isthmus, you see that coronary artery is right beneath the surface. And it's our experience that even you have to ablate more aggressively on that artery, because it's like it takes heat sink. It takes the heat out, and you have to ablate sometimes more because you have gap in that level. And as Peter said, we do about 110, 115 ablations of flutter a year in last maybe 15 years, or even more before, and we never encountered any problem with coronary artery. And there were some case reports of damage of coronary artery, but people are ablating sometimes with 50 watts or something like this. I mean, it's if you are moderate, I mean, it can be done without such a high risk. So I'm less concerned about this, but maybe in children and young people it's a bit different. But I've never seen something like this. Any more questions? Don't be shy. Anything we can discuss. Regarding maybe flutter ablation, with current experience with these really super novel technologies, I believe that flutter ablation will become very soon just very easy. No, 3. Yeah, but it depends. It depends what technology you use. We have most experience with Affera. You will see tomorrow and Monday with this lattice tip. It's 9 millimeter, and you typically do 3 lesions across the isthmus, and it's done. And you can do both pulse field, or you can do high energy RF. I remember we did a couple of years ago first cases with high energy RF with this lattice electrode, and it required typically 3 lesions, in each of them 5 seconds. So it doesn't matter what is anatomy, it doesn't matter all these things, so you just do a few lesions and that's done. With pulse field, it also works. We have some experience also with Farapulse catheter or Farawave catheter, where you put it there, although it's off-label, when you place it like almost, this basket, let's say, you put it there and you do a few lesions, it's also done. And I think there will be more catheters coming soon from different companies. So everything will be much more simplified in the near future, I believe. We are at the threshold of revolution in electrophysiology. I don't know if Peter has some comment on this.
These new novel tools are really amazing, and it's you don't never want to come back to point by point small lesion size, because obviously you don't want to mess up the heart in young person with one single muscle bundle for WPW, but if you're dealing with persistent AF or if you do covered tricuspid isthmus, the good thing about these large tip electrodes is that it doesn't give you kind of a spot and then you have to connect to the line. It just gives you a kind of highway on the isthmus, and then it's proof for any conduction because it's really wide belt of the lesion. So I believe also for the kind of efficacy and long-term kind of block on the line, it will work very well. So it will be very easy. Obviously, you still need to know how to manipulate the catheter. We still have to know how close to the AV node we can use different Farapulse or the different electroporation catheters or pulse field catheters, because that's always the notion there is that the pulse field can give you a quite large lesion, which is reversible, but you can, even from a kind of farther distance, you can do AV block. So sometimes the annulus is very squeezed, so if you use any of these pulse field devices, maybe the large ones, you may not only ablate the isthmus, but also very close to the node. This is something to really we have to learn. I'm not the one going to be the pioneer in the deciding how close you can get, but I believe it will be known quite soon.
The good thing is that the same works for mitral isthmus, and the shortest time for mitral isthmus bidirectional block I had personally was 12 seconds. 3 lesions with high energy RF, not with pulse field. With pulse field you can do probably more, but you can go also inside. But with this high energy RF from lattice electrode, in 12 seconds we interrupted conduction. So it sounds unbelievable to anybody who has experience with ablating with the conventional irrigated tip, even with contact force or whatever, but it's true. So I think and you will see the system on Monday, but also tomorrow evening. I think there is one case and from Homolka Hospital, and the beauty of that system is versatility, because you can switch between high energy RF or you can switch between pulse field. So you can decide, like posterior wall you want to ablate with the pulse field, and you can go anteriorly with RF, or you can go to mitral isthmus with RF. So that's the beauty of that technology. But there will be more technologies in the near future to be used from different manufacturers or different vendors. I'm pretty positive because I know that everybody is working now on a specific design and specific algorithm how to ablate with pulse field.
The funny thing about pulse field is that if you really repeat the pulses on the same site and you wait about 7 to 10 seconds between these pulses, it gives you additional depth. So generally, for example, for this lattice tip, if you do 4 pulses at the same spot with 8 seconds in between these pulses, the depth is bigger than the 300 watts RF, which is their standard. So it really will give us the ability to really do really large lesions, which is good and bad for some people, but I believe we will use it for good.
There was a beautiful paper by Ella Tanter recently on the use of lattice with pulse field in ventricle, in animal ventricle, and they used 1 pulse and they used 4 pulses. And if you use 4 pulses, you create lesion which is almost like centimeter in depth. But if you use a high energy RF from lattice tips, even more than 1 centimeter. And we have some experience. We did a couple of patients with this technology, with ventricular tachycardia after myocardial infarction. And you can cover big aneurysm very quickly, because each application is maybe half a minute, but the footprint is quite large. So you can really you can cover the central zone very quickly. And this is also awaited. There is still no experience with pulse field in a human ventricle, but I think that will also change a lot our strategies of substrate modification, because what is today unreachable will be easily accessible in the near future. You can go epicardial, endocardial, maybe. I believe that this will also open a new window for better success and less complications, even in ventricle level. But we still have no experience with pulse field in ventricle. Okay, no questions? No questions on chat? So either we can go for coffee, probably. Okay, so coffee break, and we restart as mentioned in your program, because there are people online, so we don't want to change scheme of or timetable of this meeting. So please reconvene according to the schedule. So I think it's in 45 minutes, if I'm not wrong.